Welcome back, everyone. In planning this meeting, PTAC wanted to prioritize hearing from those with frontline experience managing care transitions within value-based care. To that end, we invited 4 experts from across the country for this panel. You can find their full biographies posted on the ASPE PTAC website along with their slides. At this time, I ask our panelists to go ahead and turn on your video if you haven't already. After all 4 have introduced themselves, our committee members will have plenty of time to ask questions. We'll start with the introductions first. So first, we have Dr. Charles Berselius, who is the Medical Director of Post-Acute Care at BJC Medical Group. Welcome, and please begin, Chuck.
Thank you very much for having me. I have to admit, I am just retired and will be going back into clinical academic work. But in my previous role I've just left, I was the post-acute medical director for BJC Medical Group, which is basically the private practitioner arm of Washington University and Barnes-Jewish Hospital. In that role, I've been helping case management, in placing patients from the hospital into nursing homes and helping with transitions from nursing homes out to home care and to back home. I've had 35 years in nursing homes, clinic, and hospital, 5 years more administrative work. In my past iterations, I'm a past president of AMDA, which is the National Society for Post-Acute and Long-Term Care. I was a medical director of the year, public policy chair, and I work on the fee-for-service side on the AMA Relative Value Update Committee to assist in determining appropriate values for Part B services performed by physicians. Are we going to go to the next slide to summarize, or thank you? Yeah. The heart of my points today: communication and improving treatment in place. After the last talk, I'm going to add a brief comment about advanced care planning. Communication barriers in transition is a big problem. Nursing homes and hospitals, private doctors often have entirely different EMRs. And we are not at a point yet where we can seamlessly relay information across EMRs. We are far from it still at this time. We've worked on our system to produce a reliable continuity of care document to serve as a discharge summary from the skilled nursing home. Hospitals are pretty good at putting out a good discharge summary. They have the capability through their typical EMR systems. Nursing homes, however, are in an entirely different role. They did not get nearly the financial support from the federal government when we went to electronic health records, and therefore they have a much less robust system that frequently does not talk well with other systems. And in fact, when you're discharged from a nursing home, there is normally not a good discharge summary. We use a continuity of care document, but that document isn't always able to be translated by other EMR systems. There's a mapping or translation problem. So currently in my area in St. Louis, only 1 out of the 3 major nursing homes EMR have any ability to transmit information back into our hospital records. Otherwise, we're stuck with paper. If you've ever worked in a nursing home, you get people from the hospital with about 200 pages and you send them out with about 100 pages of information that's disjointed and not always in a good format. The second point I want to bring up today, improving treatment in place. The best transition is no transition. And unfortunately, about 22% of patients from the skilled nursing home go back to a hospital setting during their stay. While value-based medicine does have penalties for that in place, fee-for-service really is still at a point where it doesn't have much value. It doesn't have much of an impact yet. And in particular because of PHC, those penalties were not enacted. We've had several projects trying to keep people treated in place. I was the medical director for one in a CMMI project. We did show substantial reductions in avoidance of transition back to the nursing home. Unfortunately, this project used several different sites, several different methodologies of achieving this, and the whole project did not reach statistical significance. However, the 2 most closely ours in Indiana University showed significant results in reducing hospitalization by treating in place. Very simply, if somebody's developing sepsis, I can get an antibiotic started in less than an hour. If they go to the hospital, it's 5 hours and they're even sicker on a good day. One last item I did not put in here, but I need to put in my 2 cents worth after hearing the others talk earlier, particularly Dr. Meyer. our system is very invested in advanced care planning. And it's really goals of care we're trying to get to. Physicians tend to think of code status, full code, no code, limited code. Am I going to shock your heart or not? Goals of care is more sophisticated than that. It's what am I trying to achieve for this patient in their current status? It could be simple as an 88-year-old female saying, I want to get to my granddaughter's wedding. After that, I don't care. Sometimes it's obviously much more complicated. Currently in our hospitals now, we take the 20% sickest patients in the hospital, and the hospital gets an alert to tell them this patient is very ill, likely to return, or likely to have an adverse event in the next year. You need to have a palliative care conversation, goals of care conversation, or have palliative care see them and do this, or ultimately write why you're not getting it. That program in our hospital system has resulted in a 20% change of code status. That was not our intent. Our intent was to get goals of care listed in a particular section of the chart that people could see going forward. But we did see an immediate effect both on that, on our ICU length of stay. Our ICU length of stay and people that have undergone this is about 20 to 30% shorter as a group than those who have not had this conversation. So transition involves more than just going from one place to another. Obviously, it was talked about on the other session. It involves a lot of coordination, right timing, and right communication. So I'll hand it over to the next person.
Good afternoon. I'm David Herman, and go ahead.
Okay, I was going to say next we'll hear from David Herman, who's the Chief Executive Officer of Essentia Health. Go ahead, David.
Oh, thank you very much. I have the privilege of being the Chief Executive Officer of Essentia Health, and you can see our footprint there. We are primarily a rural healthcare provider, but we began our shift to value in 2005 when we first entered our first value-based contract. This led us to become an early adopter of dual risk side models within the Medicare Shared Savings Program and Minnesota's Medicaid initiative called Integrated Health Partnerships. Currently, we have 23 value-based programs with both government and commercial payers with more than 200,000 attributed lives. And we truly believe, and our data supports that, is that it's been said that value-based care can't be implemented in rural America, that it just doesn't work. In our experience, we found that it really is the only thing that does work. And several weeks ago, 3 of my colleagues and I had an opportunity to spend 2 hours with the Health Finance Subcommittee of the Senate Finance Committee in Washington, D.C., and provided about 2 hours of testimony just on this topic. And I can provide the link to anybody who is interested in seeing that. In order to be able to deliver that, we have had to become essentially a vertically integrated healthcare system. So we have about 15,000 colleagues, 14 hospitals, 77 clinics, with almost 80% of our revenue coming from outpatient services rather than inpatient services. In order to be able to manage and better plan those transitions of care that Charles just talked about, we've also have 6 long-term care facilities, 6 assisted living facilities and independent care facilities. And some of the appendix material that I've shown is that EMS services in rural America are very challenging as well. And we have literally have to pick up and own EMS services to provide that transportation. We have also been an early adopter of telehealth services, and we were fortunate in setting up the infrastructure to do that and making it part of our strategic plan. When the pandemic hit us, literally in March of 2020, we went from several hundred video visits today to over 3,000 video visits a day, and still maintaining a footprint of well over 1,000 of those today. In a rural footprint, as you see there, transportation and other challenges make it difficult. And what we have tried to do during this transition is not to take the in-office experience and move it to the home, but to determine what are the suite of services the patient really needs, and then leverage that home location to provide better, more rich information to help our patients on the journey to wellness. We firmly believe that each of our patients does not want to buy healthcare services. Each one of our patients wants to be healthier and avoid the healthcare services. Next slide, please. But rural healthcare is distinctly different than urban or mid-urban healthcare. And that red circle there is our surface area in Minnesota. and the demographics of that service area are the same as our service area in northern Wisconsin and the state of North Dakota. In general, patients have lower household incomes. They are certainly older. They have less education and more health concerns. At our flagship hospital here in Duluth, Minnesota, more than 30% of our inpatients on any given day have a diagnosis of diabetes, not necessarily as their admitting diagnosis, but certainly as a comorbidity. Distance to care is certainly greater. We have some of our patients, the nearest medical facility, whether it's a doctor's office, an emergency room, or an urgent care center, is 90 minutes one way from their home. And when they're back at home, they're relatively resource poor. They are generally living in food deserts. They have extremely unreliable broadband connectivity. We have advocated with the state of Minnesota and the federal government over the last 10 years to improve that, and it has improved. Yet many of our patients, for their telehealth visits, still rely upon cell phone or landline services because they don't have the bandwidth from broadband connectivity to be able to do that. We still have some very small provider practices here with a distinct lack of specialty services. So the challenge with our patients, knowing that it's not easy for them to access acute care services, is turning our service, rather than as to acute care service that initiates the care, turning our service into longitudinal service that keeps them healthy and requires them from needing that care. What we have found as we have done that it's not practical nor proper to differentiate the way we care for patients based upon their enrollment in a value-based program. What we do is we stratify our patients based upon their clinical and social needs rather than by payer. We find that to be most effective and certainly most equitable. The approach that we've adopted and that we've designed around our patients creates a model of care delivery that's as standard as possible, because we need the footprint to be able to do that, but as unique as necessary to meet the needs of our patients and our communities. So as we've made that shift, we have found it that nearly 40% of our health system, rural health system revenue flows through value-based programs, and we actively continue to grow that share. What allows us to do that is we have a strong clinical and information technology infrastructure. We are an epic from front to back. It allows us to understand our patient populations and screen for not just the social determinants of health, but the social characteristics that affect their health outcomes. In 2022, more than 144,000 of our patients completed our health-related social needs screening, and more than 20,000 of our patients identified at least one social need related to food insecurity, transportation insecurity, or financial difficulties. We then try to partner with our communities to help provide those services, yet what we sometimes find is that leads us on a road to nowhere, that in many of these rural communities that we don't have those services, so we work as a healthcare system to be able to do that. We are proud to do this. We believe this is the best way to do that. I'm looking forward to the conversation this afternoon to determine how we can work better together to reduce some of the barriers, some of them payment and some of them regulatory, that allow us to, that are keeping us from taking the next step on this.
Thank you, David. That's actually fascinating. Looking forward to hearing more about that. Next, we have Jenny Reed, who is the Senior Vice President of Value-Based Care at Baylor Scott & White Health. Jenny?
Hi, good afternoon, everyone, and thanks for having me. I lead Baylor Scott & White Health Quality Alliance, which is a clinically integrated network of 8,500 providers across geography the size of the state of Virginia, which makes us the largest not-for-profit healthcare provider in the state of Texas. Over 700 facilities, and just for context, in transitions of care, only about 50 of those are hospitals, and all the rest are various post-acute providers across our geographies in order to serve the locations of our members. We provide value-based care services for about 1 million lives. I've spent the first 10 years of my career, my background is in social work. I'm a licensed clinical social worker by education and training. Spent my first half of my career in acute care case management, planning transitions for folks, and observing all the challenges, many of which my colleagues have already described, although I would say Dallas-Fort Worth is the opposite of rural health care, and I look forward to learning from Essentia. Our challenge is more in that we have an abundance of healthcare providers, and so trying to maintain continuity in an environment where there's a different provider on pretty much every corner is the challenge we face in a metropolitan area. I heard a statistic at one point that 1/8 of the home health care in the United States of America existed in the state of Texas. So connecting the dots longitudinally for patients has been a huge challenge for us to overcome over the 10 years that the Quality Alliance has been in existence and managing value-based populations. On the next slide, I'll describe a little bit more detail. We've participated in Medicare Shared Savings since 2017, began taking downside risk in the second half of 2019, and have earned the most savings for the past 2 years, nearly $300 million. There's about 130,000 members in that population, and the learning that we've had in managing those has been quite a bit of opportunity, one of which is how we keep folks in a network. Primary care is a great quarterback when you can get patients connected to them. Really, again, with the abundance of providers in any given geography, being able to manage within a network as opposed to, I heard someone mention regulatory challenges of patients having access and choice. How we start to balance choice with quality of care and continuity of care is a challenge I think we'd love to work together with this committee, CMS, others on solving. We know that when we can keep folks within a network that has visibility to all their care needs and all the care they're receiving across locations, we see better outcomes. When we first started in 2017, we had about a 40% network utilization, meaning those patients' care was visible to their primary care providers. We've increased that to about 80% of the patients in our Medicare Shared Savings Program have been with us for 2 years with the same primary care provider in the same network. And we believe that is paramount to how we've been able to achieve the savings that we've achieved for both CMS and to reinvest in the programs. What we do with our shared savings is reinvest them in additional programs, both digital and face-to-face type of solutions, innovative solutions to provide better care to those Medicare patients over time. Comprehensive care management is one of the things that we do. So I mentioned being an inpatient case manager at the beginning of my career. We've built longitudinal case management. We know in our Medicare populations that those patients who engage with that program, we save about $83 per member per month on average, but for those with chronic conditions, more like about $1,200 per member per year, which across a system the size of ours is a considerable savings for all those involved. We've seen our readmission rate reduce, acute hospitalizations, et cetera. One of the things we did in the readmission space with our earnings is invested in a digital care coach. I am a firm believer that there are lots of things we can do electronically. The only way we're going to successfully manage these programs is if we create non-people oriented solutions and how we use our data better across time, because we need to reduce the total cost of delivering healthcare in our country. That's the only way these models will be sustainable. So we have reinvested our savings in a digital care coach that helps folks manage their transition to home and can escalate to a human interaction as needed. We've seen our post-acute care utilization reduce quite a bit as well by implementing better methods to determine what level of post-acute care is needed, by working with those providers, again, balancing choice with high-quality providers and implementing ways for patients to make informed choice about which providers they're going to work with when they leave our hospitals. and we've increased our continuity of care there as well. We've also reduced our length of stay in skilled nursing facilities by working directly with the skilled nursing facility staff, again, transmitting data, doing advanced care planning, making sure the plan we put together in primary care travels to the hospital, travels to the post-acute care provider, so that patient, families, physicians, care team are all on the same page about goals of care and what needs to happen in the various different care settings. So I am a huge advocate for longitudinal total cost of care models that incentivize innovation and allow providers to reinvest in a new way of delivering healthcare across our markets. And I look forward to the discussion today.
Great, thank you, Jenny. Next is Dr. Robert Wachter. He's a professor and chair of the Department of Medicine at the University of California, San Francisco. Bob?
Thanks so much. Thanks for the opportunity to speak today, and I've enjoyed the prior 3 discussions and agree with a lot of what I've heard. I think the next slide is just the one my mother sent in about my bio, and won't spend much time at it other than to say that my day job, if you could turn to the next slide, maybe not. My day job is I'm chair of the Department of Medicine at UCSF, so a very large academic health system, about a $6 billion a year, increasingly networked health system in San Francisco, and have about 1,000 physicians in internal medicine in my department. Other than that, my perspective, I think I was asked to take on the hospitalist perspective. I coined that term now 30-ish years ago, and it became the fastest growing field in the United States. So most of the inpatient care in the country is delivered by this specialty that didn't exist 30 years ago, called hospitalist. So we have a very much central perspective on the challenges of inpatient care. I've spent a lot of my career thinking about patient safety and writing about it. I've also spent the last 10 years or so thinking a lot about digital transformation, and endorse the comments you've heard already that we're not going to get to where we need to get to without focusing on some digital solutions that we don't have today. And I think particularly, I think it was Charles's comment about the importance of interoperability. We spent $30 billion helping to digitize hospitals and doctors' offices, but did not digitize the post-acute world, and that has created a huge voltage drop between when patients are hospitalized, now in essentially 100% digital systems with electronic health records, and then they go to other settings where they don't have that. And so it's a strategic and systematic flaw in the system. And I'll just go on to the next slide to kind of talk about a few of these issues from the perspective of hospitalists. Let me just say and give you a little bit about my own personal perspective at UCSF. Our hospital, like a lot of big academic hospitals, certainly in urban settings, tends to run very, very full. I think we are seeing some change in the marketplace where the big players in many markets are full and the small to mid-sized hospitals tend not to be full. And we have a few hospitals in San Francisco that are 50% full, while we're 110% full, and obviously talking about strategic alliances between those two groups all the time. But the fact that we are full creates powerful incentives for us to move people through the hospital system as quickly and safely as possible. And sometimes that involves trying to send them to post-acute settings. And sometimes it involves, and it really hasn't come up so far, but I think it's important to raise the point, it involves thinking about whether they can be cared for safely at home from the beginning. So do they really need to be in a hospital, or could they be cared for in a hospital at home model? Let me just say a word about that now. I find hospital at home to be incredibly interesting because the original articles talking about the value of hospital at home, that in fact it can deliver care that is as good, if not better, than care in the hospital at often half the price. The original article supporting that premise came out at about the same time that my article supporting hospitalists came out in the late 90s. And within 5 to 10 years, there were 50,000 hospitalists in the country, but essentially no hospital at home programs. And even now, 30 years later, hospital home remains a fairly fledgling model. And that, I think, is largely because of the regulatory and payment challenges. The hospitalist model, once people believed it was a better mousetrap, there weren't any major regulatory or payment issues to overcome, and it very quickly became the dominant model for inpatient care. Whereas hospital at home, even today in California, as we think about making a major investment in hospital at home, we still worry about how long is Medicare going to be supportive of the model? Will the rug be pulled out from it? And as long as there's that uncertainty, I don't think hospital home will achieve its potential. And I think its potential is very, very large. I think probably 10 to 20, maybe even a little higher percentage of patients who are currently in hospitals could be cared for in home settings with digital augmentation if the payment and regulatory signals were clear. And right now they're still kind of murky. And as long as they're murky, we see the companies that are in that space are all a little bit uncertain in terms of their future. So I think in some ways that may be one of the more important things that can be done by the federal government, which send a clear and unambiguous signal supporting hospital at home, both in terms of payment and regulatory changes. The other issues I put up here are the three kind of pet peeves for hospitals and hospitalists. And again, from our perspective, we're taking care of patients, many of whom, I'd say the vast majority of whom needed to be in the hospital for a period of time, maybe independent of the hospital home question, but could potentially be discharged to the next level of care. And we find in many, many cases they could be, but they can't be because there is simply not capacity in the skilled nursing facility or long-term care facilities. And capacity is sometimes they don't have the space, sometimes they don't have the nurses, sometimes the payments that they're going to be getting are not attractive enough for them to want to take a patient. And the result is a hospital like mine tends to be very full, which leads to an overfilled emergency department because the patients can't get out of the ER to go upstairs, and the entire system sort of breaks down. So one pet peeve is the 3 midnight rule, which increasingly seems antiquated, not the right call to make patients stay in the hospital for multiple days in order to be eligible for skilled nursing facility payment. Another is just a hospital issue, which is if sometimes we have long stay patients that we cannot send any other place and we don't get compensated for that. And the third, which is a theme I think you've heard from others, is I think the world is a better place if we can come up with better bundled care models that provide the appropriate incentives so that we can work together with post-acute facilities to try to figure out the right place for patients and all of us get compensated in the right way. Right now in San Francisco, we still have a lot of our patients are under fee-for-service models where the incentives aren't aligned to get the patients to the right place at the right time. So I'd say those are the main things that I wanted to bring up, but very much want to endorse some of the comments of my colleagues and say particularly on interoperability, it's absolutely going to be vital that we figure out a way of wiring and digitizing the post-acute environment and connecting the hospital and the post-acute settings. And it's very clear if you look back at 2008, 2009, prior to that, 10% of hospitals had electronic health records, and 5 years later, 10% did not. And that took a federal investment of $30 billion. It wasn't a huge investment to essentially digitize a $4 trillion healthcare system. And obviously, we didn't get it perfectly right, but I think it's created a foundation for much, much better, safer, and ultimately less expensive care. I think the fact that we left nursing homes out of that at the time is understandable, but now would be a good time to figure out how to digitize the rest of the system and to connect all the parts. So I will stop there, and thanks again for the opportunity.
Thank you, Bob. And at this time, I'll remind the PTAC members that as you have questions, if you can flip your name tent over so we can recognize you have a question. All four great presentations and all four obviously very successful health systems. And it's obviously taken you all a while to get there. And so kind of part of our question is, how do we get the rest of the country where you are? And then how do we allow you all to continue to improve? And so kind of get some of the conversation for this afternoon flowing, I'd like to go back and just kind of get you all to identify what did you see as your barriers to get where you are today? both from a payment and regulatory standpoint, and how did you overcome those? And kind of where are you today, and what kinds of things do you still see that we need to overcome to continue to move forward and to grow value-based care across the rest of the country? And I'll start with Dr. Herman.
Thank you very much. Some really good information here today. I think the first thing, the thing that was holding us back, we were Medicare shared savings, but we were track 1. And when we looked at what it would take to get to track 3, when you sit down and talk with your finance people, you talk with others, the first thing they're going to say is, well, you're going to lose money on this. So I think it really requires a commitment from leadership, which we did in this organization, where we said, if you tell me we're going to lose $4 million, then let's book the $4 million and find it someplace else. But let's make the commitment to do this. I also believe people talk about having a foot in the dock and a foot in the canoe. You're just going to, and here in Minnesota, we just get in the canoe. We don't spend a lot of time on the dock. What you're going to have to do is you're going to have to decide to treat every one of your patients that way to do that. I do think that if you're a smaller provider, small numbers can really doom you to be successful in this. I think you have to do something different for smaller providers than you do for an organization like ours that's $3 billion. We have the numbers where we can show the differences. We can show how we've made a difference, how we've saved money. But if you're in a small rural practice where you have a panel of perhaps 5,000 to 6,000 patients, one very ill patient is going to skew your finances in the wrong direction, where it will show that you're not really saving money when in fact you are saving money. What we also believe is that, of course, the unit cost of healthcare is incredibly important. Yet decreasing the overall burden of disease is beneficial both from a cost standpoint and from a population health standpoint. So what we try to do is make investments in the community while we can, and then continue to move that going forward. From a digital health standpoint, and I mentioned this in my Senate testimony, there are so many barriers around telehealth at this particular point in time that it makes it hard to deliver it. And I do understand the concerns about fraud in the telehealth space, but at the same time, I used a bird feeder analogy. I can design a bird feeder to keep all the squirrels out, but I can guarantee you it's going to keep all the birds out as well. What we have to do is have incentives to continue to push this digital home-based care or community-based care forward. Of course, deal with the people in the fraud, but let's not do this with overarching rules and regulation that makes it difficult to do that. I'll give you a quick example. I have some of my providers that are concerned about reaching out to their patients on an every other day basis for a 2 or 5 minute check-in just to make sure they're doing well, because that's what keeps them out of the hospital. Yet, if they were just acute care providers in a small little urgent care someplace and did that, they wouldn't have that continuity of care, and they would be less at risk from bouncing up onto that regulatory dashboard that says, boy, this person seems to be, quote, overusing digital care or overusing home care. I could go on. I will turn it over to the rest of my colleagues for their comments as well.
That was great comments. Let's go to Jenny next.
Sure. I think I'll choose to go a little bit deeper on the regulatory issue that I mentioned earlier around patient choice. I do believe in patient choice and autonomy, self-efficacy. However, I do think that we, in any new model, need to consider the opportunity to help patients have an informed ability to choose. I think there's some regulations out there. The STARS program, I guess, is a place to start, but equipping providers with more of an ability to let patients know things like this group can see our records or has adopted our same standards of care that your primary care provider has adopted, et cetera, can help patients choose the next level of care provider that would be best suited for them. I think sometimes regulatory environment is seen as being a barrier, or has been for us a barrier to guiding patients in the way that we know they're going to get their best outcome, because we want it to be a choice-free and clear. So not necessarily proposing the right answer, but I do think we need to work together to find a middle ground, so that we don't, to the point about telehealth, enable providers who maybe have nefarious intent. I think the gross majority really want to do a good job. The other thing that I think we used that really helped us was the bonus program in the advanced payment. The APM bonus was really an incentive to get involved and be able to reinvest in new ways of providing care. So when we took risk in MSSP, that was a big deciding factor. It was also a clear math calculation that could be done with our finance people to show what dollars we would use to fund the additional investment required to stand up care management, to stand up a digital transitions of care management program. Sometimes we overcomplicate those calculations. Readmission penalty, as an example, is a really hard connection to make between provider and outcome and what that eventually does to my business model. And so when it's too complicated to understand, a lot of times what we as providers do is just kind of go over here and do the best we can, but it's not clear, can I spend $1 to fix that problem, or can I spend $1 million to fix that problem? So I think the more simple and clear we could make the calculations, the better. I agree with the comments about the 3 midnight rule and the bundle payment initiative. One thing that concerns me, though, about episode-based payments is that they center around hospitalization. In other words, a patient has to be admitted in order to be eligible for a bundle. There's not an incentive to discharge that patient from the ER. So models that have a connectedness across a community of care providers would be more of interest to me in the way that it connects outpatient and ambulatory to the hospital and to the post-acute care providers, and I think lends itself to more innovation. By the same token, I don't love models that put the primary care provider on their own and don't integrate with hospital care, because you're going to have patients that get sick enough that need hospital care. So models that incentivize working together as a provider community and including all levels of care are the ones that I have seen be most effective, because you're not solving one problem at the expense of another provider in a different location, if that makes sense. So I think to summarize my comments, clear calculation, regulatory leeway in terms of informed choice or informed consent for choice of provider, and models that include all levels of care or all care sites, primary care, specialists, hospitals, post-acute, rather than models that further segment care providers into an acute bucket or a PCP bucket and cause us to be further disintegrated at the expense of each other, are my 3 top recommendations.
Perfect, thank you. Next, I'll ask Charles to go.
Yes, a couple of points. Building on to that, currently my long-term care nurse home patients with acute medical problems have to go to the hospital in order to get the level of service they often need to get adequate reimbursement. There is no way to put that long-term care patient in a skilled bed. During the PHC, that was suspended, and we don't have all the information back yet on how successful that was and whether there was advantage taking of it. However, with the right safeguards in place, allowing long-term care patients to go directly to SNF and bypass the hospital would be immensely helpful. The nurse home provide the typical IV fluids, IV antibiotics. I can basically get any diagnostic test there but a CT scan. They're not portable enough yet. But I can handle a large majority of ill long-term care patients if I could have the capacity to ask the home to do that. Right now, we ask the home to pay for the IV fluids, the nursing time, everything out of their pocket. And that takes a lot of their per diem. In the demonstration project we had, we could do this. The CMMI project from a few years ago. It was very successful. I encourage the nurse home to build up their testing capacity. Things as simple as a bladder scanner. Is somebody in urinary retention? That piece of equipment costs a bit of money. And if we don't supply homes with the right equipment to test for the right things, we end up spending more money. On a different note, I want to go back to the communication piece I mentioned earlier. We have enough communication in the style we think the next person wants it. We often don't ask them. In our system, we went to the nursing homes, to the home care, and say, what do you need in a discharge summary that would make this helpful for you? And we got together there for a good discharge summary. We've automated systems like Epic. The hospital systems are robust enough. I don't have to ask hospital medicine to lift a finger to put this information. The diet they're getting in the hospital, the actual wound, the pictures, the size, what's being applied to it. Do they have any lines, drains, airways? When was their last bowel movement? All that is in one location. You can easily pull from the hospital records. So we've gone from sending over 200 pages to sending about 15 pages of information. That's the core information they need. Now, obviously, in the system, the hospital has to do the discharge summary by the time the patient leaves. So our financial incentive is the hospital gets a 1% bonus for hitting a threshold of discharge summaries by time of discharge. And we track all the physicians, so they get immediate feedback on where they stand. Every month they can see how they're doing. We're a 12 hospital system. In 6 of our community hospitals, we're getting 100% of the discharge summaries done by time of discharge. So when that person leaves and goes to home care or the nurse home, they've got the information. And while we constructed this for the nurse home, we found out our PCPs actually like this information. It saves them a lot of time. Our patients going back to the office normally don't have pressure ulcers, for example, but they've got some problems and they've got some information. They may have a pressure ulcer here or there. The diet may not be fully understood. Unfortunately, hospital medicine and their pressure sometimes puts resume previous diet. Doesn't mean anything to a nursing home, and sometimes doesn't mean anything to their home. They go back home and it just reinforces the fact they've been eating too much sugar and salt. Or I could resume the same diet. So getting granular with the discharge summary, but discrete, specific, incentivizing it by the hospitals and embedding that in systems of payment would be helpful in a fee-for-service world, much less managed care.
Perfect. Thank you. Bob?
Yeah, let me start with your premise, Dr. Sinopoli, that we all have our acts together. It reminds me of the late Israeli Prime Minister Golda Meir, who once said, "Don't be humble. You're not that great." I think we're not. I think that we're not that great. We're all working on it and all. I think getting better, but there's a lot of work to do. As I hear this conversation, one of the things that strikes me that has not come up yet is the, at least in my region, the Bay Area, massive shortage of primary care doctors. And so any system that's premised on the primary care doctor being the orchestra conductor for patients as they move through transitions, at least in our world, is destined to fail. Primary care, I think, I've old enough to have seen many primary care crises, and that lots of calls for changes in the way we compensate and support primary care doctors. I think the need has never been greater, in part because of they're now suffering under the weight of the electronic inbox that patients now have patient portals, digital patient portals, and do what would be perfectly rational for them to do, which is send a bunch of messages to their doctors. And so I do think we have to address the absence or the lack of primary care infrastructure under any system that is premised on the primary care doctor being the quarterback for patients as they move across transitions. Not much to add to what I heard. I do think the issue of regulatory sort of relief in the telemedicine space is really important. I think everybody, of course, understands the issues of fraud and that we've got to be thoughtful about it and careful about it. On the other hand, what we learned during the pandemic was how valuable telehealth can be and how effective it can be. And one of the things we're seeing in California is the resurrection of state-by-state licensure requirements, which for us as a tertiary quaternary center, we've got lots of patients who come to UCSF from Nevada or Arizona or other states, and it's now become extraordinarily difficult to continue to provide telehealth services to them. And that, I just think, doesn't make a whole lot of sense. You think about the medicine that should be practiced across state lines is about the same as it is in any given state. And we've resurrected a barrier to telemedicine that I think we should be trying very hard to take down again. But otherwise, I agree with the comments I've heard, and I don't think I've got all that much to add.
Thank you. We have some questions from our PTAC members. So, Chini, you want to go next?
Thank you to the panel. This has been a great discussion. One of the things, this is directed towards Dr. Wechter and then anybody else who'd like to opine. One of the things we saw during the pandemic, to your point, is that there was greater provider adoption of telehealth. I think patient adoption was always something that was potential to be there, but the provider adoption came during COVID. A lot of that was driven by not just the necessity of the pandemic, but the fact that there was parity in reimbursement, right? So as we think about hospital at home, Dr. Wechter, and I've seen different studies on whether outcomes are better versus not. I've seen international platforms that have tried it. I'd love to get your opinion on, do you think that's the future to sort of creating more margin for hospitals and sort of doing the right thing for the patient without heads in beds? And B, if you were to do that, would you approach it with having parity in the beginning versus arbitrage in payment?
Yeah, thank you. It's a really good question. I guess I would start by saying that creating an environment for hospital at home is tricky and will take an investment on someone's part. I mean, to me, the core issue, one of the core issues at least, was the emergence of companies, and I don't have any financial interest in any of them, I'm just as an observer, that could do the supply chain piece of hospital at home. Until you had an environment where a doctor in an emergency room would find it just as easy to say this patient can go to hospital at home as it is to say this patient can go upstairs to the 10th floor where there's a bed waiting, then hospital at home was always going to lose. So the question is, can you create a financial and regulatory environment where whoever is going to run hospital at home, let's say it's a healthcare system that has hospitals, has enough of a market and regulatory signal that they are willing to invest in it, because it's a complex set of changes. There's some cultural changes. There are obviously workflow and workforce changes, and that the companies entering that space largely to do the logistics, to be able to, with a single phone call, deliver oxygen and IVs and a respiratory therapist and all that kind of stuff. The companies have enough of a signal that they can make it in the market. And I think right now the signal is just not strong enough for widespread adoption. Does there have to be parity? I think that's an empirically testable question. It has to be lucrative enough that the hospital believes that it's worth its own investment and the pain and the trouble of doing it. If it's a break-even investment, they probably won't do it. The exception to that might be a hospital like mine that's 110% full and is sending away thousands of potential new patients a year, including transfer patients that need tertiary and quaternary care that we're relatively uniquely situated to provide. For us, even if we broke even on hospital at home, or maybe at a tiny margin, we'd still find it valuable because it opens up beds for other patients. But does it need to be paid at parity, or does it need to be paid at enough to provide a reasonable margin for hospitals? I think that's an empiric question. Maybe it needs to be parity for a while everybody sort of makes the initial investments. But ultimately, it should be cheaper to, not have the fixed infrastructure of hospital beds. And therefore, the idea that you have to pay at parity forever, that doesn't sound right. But if there's not a reasonable margin in the short term, I don't think you're going to hit the activation energy that's necessary to deliver. I don't think telemedicine is the right analogy, because the infrastructure that was necessary to stand up a telemedicine program was pretty trivial. Whereas the infrastructure and the fixed costs and the political challenges and the operational and workforce challenges of standing up a hospital at home program is really pretty significant. And you're just not going to do it unless you are pretty confident that this is here to stay and that we're going to make a reasonable margin on it, at least in the short term. And so, whether that's parity or a reasonable margin that's not quite parity, I really don't know. I think that has to be tested.
I agree with Dr. Wachter, and I would also look at it from the short-term side as a utility function. I mean, the United States didn't move everyone from burning kerosene lamps to electrifying the homes by saying, "Well, tell you what, if you can sell electricity, deliver electricity as cheaply to the home from day one as you can to fill up a kerosene lamp, we would still be using kerosene lamps." What we did, as Dr. Wachter said, is provide funds to build that infrastructure to be able to do that. I would also support Dr. Wachter's thing about we're never going to have the number of primary care physicians that the current model is set it will need. And I will even take it further. We will never have the number of people that the current model says we need to do this. We grew healthcare in the 1980s and 1990s when America had the largest high school graduating classes and the largest college graduating classes. So I have people in my office all the time saying, if you can just get me more people, but those people don't exist. So we're going to have to take a step back and redesign our care that's less dependent on people that did things that don't require people and be able to work it out that way, to hope that someday we're going to have a bunch of primary care providers or more nurses or more people in the nursing home. Those people just don't exist.
I would add, just as a very pragmatic issue, as we do more digital transformation, the labor shortages creates an environment where the politics are easier. We're not talking about AI or digital automation and therefore having to lay off a whole bunch of people. We're talking about doing things that we can't find enough people to do them. If there were enough people, you would deal with much more complex labor issues and union issues and all that. But in many cases, that's not the issue. The issue is we can't find enough people to do these things.
Any other comments from the panel?
I'll just offer an anecdotal agreement about hospital at home and shortage of people. We tried hospital at home unsuccessfully 2 years prior to the pandemic, 1 year prior to the pandemic, 6 months prior to the pandemic. And it's a little bit of striking while the iron was hot because we were lacking capacity, as Dr. Wachter said, and employing agency nurses at a rate that we hadn't seen ever. The idea of using technology and treating people in the home was much less, as you said, political, challenging. It was sort of a great environment to introduce something that otherwise might have been controversial. I think there's some other learnings we could get from that and ways to implement innovation in this challenging time. There's some innovations that we could pick up and dust off and probably be more successful than we were before. So agree with all the comments.
Yeah, I'd agree too. We've had great difficulty with staffing. It also goes across nursing home and home care. In any model you design, you're going to have to figure that out also. There's a great role potentially for home care and hospital at home and keeping people home and community-based service. But we're sort of at a stalemate in our system and how we can advance with the staffing shortage.
If I could make a quick comment on home care services in rural areas, they're much easier to do it in an urban area because if you're taking care of Mrs. Jones and then you go to take care of Mr. Smith, it can be a half a mile away. If you're taking care of those same two people in a rural area, it can be 40 miles away. So needing to have a certain number of visits, particularly hospital at home, how many visits do you need during the course of a day? From a rural health standpoint, it makes it almost impossible to scale because the distances are just so long. If you can do it digitally, and I think you'd be much more successful rural.
Good. Thank you all. Jim, you have a question?
Sure, thank you. Given that there is a labor challenge, at licensed as well as professional levels that a number of you've already mentioned, we understand that more effort by a limited labor supply using new digital tools is somehow the combination that's necessary to do a better job at this, so that the money, the quality goes up and the costs go down. Could you comment on what you think incentives, financial incentives or other, would be helpful for that limited labor at all levels, licensed versus professional, might need in order to do better work per unit of labor to accomplish this improvement? And the introduction of new tools, right? So does all the money need to go into digital reengineering, or does some of it need to be spent focused on incentivizing the labor? And the two labors I would describe would be that which is employed, that you have direct control over by employment, and that which is really independent still. Maybe and do we really have to vertically integrate the entire system legally, financially, or in some places, do you have to keep it independent, some hybrid?
You want to direct that to one of them, Jim? Or just the whole panel?
Anybody that thought they'd like to take it, I was hopeful.
Okay.
That's a really tough one. I mean, we are trying to get everybody to practice to their highest level of capabilities. We've got MA doing nurse home, for example. We send an MA in to do telemedicine to gather information. So our physicians walk in, they can be as efficient as possible, get in and get out. There's more LPNs than there are RNs now in a lot of markets. LPNs can't assess for me, but they can do a pretty good job of observation when trained appropriately, especially in a nurse home, can perform near the level of an RN. I think we're going to have to look for lower skilled people to do more work, frankly, in order to solve the economic problems this is going to face. I'd be interested to hear what others say.
I think one of the challenges we have for innovating and changing our care model, it depends on where you start the design. I think one of the faults that we start the design with what we're doing now and how do we do that with fewer people, rather than starting what does the patient need to improve their health and to sustain their health. We need to start in that second spot and design it new rather than start where we are. I do think from the challenge, is it employment or is it a hybrid model? I think it determines the area that you have the scale. One of the things that one of the reasons we're in the ambulance business is that we have the scale to be able to do that. No small community has the scale to be able to do that. So I think that'll depend particularly upon the area and the skills of the people that you have. But we're going to have to start in a different place rather than where we are right now and how we're going to do with fewer people, rather than saying, what is the type of health care that we need to get the health status that we want?
Let me just double down on kind of what I said before about high tech. I think in general, it's not a great idea for the government to choose winners and losers in terms of technology, or make targeted investments in technology. Technology moves too fast. It's not nimble enough. I more trust the provider organizations to say that the combination of people and technology is going to work really well here, and this is the company I'm going to bet on in order to get us to a place where we're delivering more value. I think the exception to that is the kind of foundational infrastructure technology, in some ways like what David was saying about electrifying the system or building the highway system. If we had not invested in high tech and meaningful use, I'd suspect we'd be at 30 to 50% electronic health record implementation in hospitals, and probably about the same percent in doctors' offices. So a targeted investment on creating that infrastructure It certainly didn't solve everything, and it created some new problems, but it created a foundational, it created a set of conditions on which we could have a system that's entirely wired and digital, where all of the elements of the system are moving data seamlessly through the system. And as we come up with better tools and analytics, I mean, nobody could have envisioned GPT-4 when we did high tech in 2009. But our ability to take advantage of new AI tools will be markedly enhanced by the fact that we have these electronic health records and all of the data are in one place, except for the post-acute and home care settings. And so I think you can make a very reasonable argument that the same kind of investment that we made to digitize the hospitals and doctors' offices could and should be extended to post-acute care. And that would be actually a fairly, I think, a wise investment. I don't know what the math would be, but I'm guessing with a $5 or $10 billion investment, you could probably digitize the entire system and create the foundational conditions for a much, much, much better continuity of care and much more seamless transitions than what we'll ever get, because I don't think without that kind of core investment, your local skilled nursing facility will ever build, buy an electronic health record. Maybe if they're part of a big system like the four of us are in, maybe we eventually will buy SNFs and buy nursing, buy long-term care facilities and put in our instance of Epic or Cerner. But I think counting on that is a pretty inefficient way to do it. I do think this would be an area where a federal investment would be super helpful. Obviously, it's a lot of money, but I don't think you get to where you want to get to from the standpoint of continuity of care and seamless transitions with 2/3 of the system wired and 1/3 of the system using paper.
Yeah, I would agree with that, and I think incentivizing the minimum or the capability without necessarily funding a particular brand of those capabilities is what I hear us kind of landing on. And then what ends up happening in America is we end up picking the winner by who executes the best over time. And that's why we started with 1 million different electronic health records. We've got Epic and Cerner and I think Athena, probably in the independent space. I was going a little bit different place with how I was contemplating answering the question, maybe just because I work in the same market as Dr. Walton. And when he says employed and independent, I think more about providers and how we incentivize provider behavior. But same idea, what are the minimum capabilities or programming that we think need to happen for Medicare members, and how do we incentivize the behavior we want to see repeated? I think, again, it has to be very clear. If I do this, then I get this for it, rather than some really complicated, BPCI had potential, but when you're still reconciling the program 3 years later and sending money back or receiving money from the federal government, those types of programs are difficult to understand and sustain. So where we can connect incentives with the behavior we want to see, I think we will be more successful. We've done that with quality metrics. Utilization's a little bit different. But most of the post-acute care in America was created when we moved to DRG payments for hospitals. So we understand cause and effect relationships of payment models and how those create sort of some different ways of providing care. I think spending time not starting where we are, but understanding what patients need and how we got to where we are. Maybe there's some good lessons about how we could build the next iteration of we were DRG payment hospitals at risk for payment. How do you start to make the entirety of the delivery system responsible? I wanted to comment on your shortage of primary care. Just briefly, in our hospitals, 15 to 30% of the Medicare patients in our hospitals are attributed to one of our value-based programs, one of our primary care providers. What that means is the other 70 to 85% of the Medicare patients in any of our beds right now today are attributed to no one or are attributed to primary care in the community who are not connected to our clinically integrated network. They could be connected to the hospital across town. our patients could be in those hospitals. And that's where I feel like the current programs focused only on primary care are not, or hospital episodes are not integrated enough to really incentivize the change that we're trying to see. There is no incentive for a primary care provider who's taking risk on a population to necessarily connect to other providers in the community and make transitions of care better, other than what it means for them. But what's the incentive for a hospital to work with those providers and figure out a better transition of care? There isn't one. There's only one where that hospital has some skin in the game. I don't know how to say it more eloquently than that. When we start dividing the providers the way that we have in these different programs, the connectedness, the willingness or the necessity of connectedness will start to deteriorate. So I think incentives or programs where there's an incentive for the hospital to do their part the very best they can, for the primary care provider, if there is one, to do the very best they can, for medical subspecialties who can have attribution today, to get credit for, cardiologists taking care of a heart failure patient and serving as the primary care. I think there's some opportunities to further think through incentives that align those folks who are working well together, or incentivize them to work together rather than compartmentalizing the different pieces of healthcare. But that's a lot. I could go on forever, so I'll stop. But I'll say incentivizing the behavior we want to see repeated and incentivizing those minimum capabilities. Dr. Wecker, I agree with you. Getting everyone's information visible so it can be used as discrete data that we can use to inform an improvement in the way we deliver healthcare, I think is a great starting point.
Any other comments? If not, we'll move on to Lauren.
I have a two-part question for you. Building on the last question, you've all talked about longitudinal management across sectors, across systems, and really building capacity for a shift to anticipatory symptom and disease management. And you've talked about financially incentivizing that behavior change, but I'm curious if there are practices or education that has also created that kind of change that you've learned outside of traditional care management kinds of things. What was the lock and key sort of change to shift people to a very different way of looking at client management across sectors and systems?
I know this is about payment, but I'll tell you a quick story about our organization. We used to have about 10% of our providers' compensation at risk for quality measures, coordination measures, and it was the most divisive thing we had in our system. And it just made everyone unhappy. I couldn't see where it was driving the results that we wanted. And so we said, okay, we're going to sunset that. But what we're going to do is we're going to have standard work, and we're going to build the infrastructure underneath that to make the right thing to do the easy thing to do. And we found that to be much more successful than the incentive model. We certainly, I don't believe that payment models really work to drive change. I believe that payment models have to be aligned with change, but it's been my experience that we have to make sure that there are a lot of great people that want to do great stuff. We got to get their barriers out of the way and make that standard work the easiest thing to do rather than incenting people to do that. I would also say that we have talked about the post-acute, but I don't think we've talked enough about what you do before the person hits the emergency room and what are the health-related social factors. We found that partnership with our public health nursing, interestingly, law enforcement and public safety are some of our, particularly from the behavioral health standpoint and the homeless standpoint, are some of our biggest allies on that. So the health of a community doesn't just sit within the healthcare system, no matter how well integrated. There's many social factors that sit around that I think provide a lot to drive a lot more of the health outcomes of our patient and a lot more of the cost of their care.
I'm going to ask one follow-on question to that, which was part two, and then give everybody else a chance to add in. So I completely agree with you. I spend a lot of time in that space. One of the other things that comes up as you start looking at cross-sector integration of social determinants or health-related social needs and really integrating across settings is HIPAA. So people's terrible fear that we cannot share information to coordinate care and coordinate delivery. So I'm curious how you've addressed that in delivery in such a broad network.
So one thing that we did is in a previous job that I had, we actually developed a trusted third-party intermediary that held all that information. So the hospital could put it in it, the healthcare providers could put it in it, public health could put it in it, and then we formed that group to be able to share that information, of course, with the permission of the people that were involved. I also have to add that when I sat with a group on the NQF where we talked about how do you integrate care, we actually made many of these measures and many of these payments to the hospitals because we felt that the hospitals had the most powerful seat to drive that coordination. I still believe that that's true, but it's still not a sufficient enough of a power or enough of a driver to have that coordination. So we need to start thinking more broadly than just the hospitals or acute care facilities driving the coordination within a community.
Any of our other presenters want to comment on that two-tiered question?
We use patient-centered medical home certification as the way to first create awareness of what wasn't happening. I think, one of my predecessors would always start that conversation by saying providers think are taking good care of their diabetics. The ones that are in front of them that are coming to see them, what we forget about is what's happening to the people that we can't see and what's going on kind of behind the scenes. So using the electronic health, it's a great use case for the electronic health record, by the way, creating registries, creating visibility of who all is my patient and what things should be happening to them. So that was where we started to raise awareness of, are you doing all the things that you set out to do for all of the patients who consider you their provider? And that was a great way to get buy-in. I think what we knew is that we needed staff, so coupling that with funding mechanisms so that we could augment what the provider was able to do on their own versus what a care team can do, and how we can add, right now, at that time it was people, we have automated a lot of those processes now, thank goodness, and decrease the cost of delivering those services. But that's an example where I would say the funding that was available and the electronic health record worked together to be able to not incentivize the providers like you get a reward for doing what you set out to do, but just to give them the funding they need for the resources to do it well. So I want to be careful not to get the word incentive sounding like a bonus payment in someone's pocket. It's really just dollars that you can reinvest in equipping our providers and our healthcare system with the resources and tools it needs to do that well.
Thank you.
Yeah, it's Dr. Mercedes. I'd add to it real quick. Incentives you do have to be careful with, but we found certain incentives do work for right groups of people. What does work as well is just comparative analysis, as Jenny was pointing out. If you just say, Dr. B, you're at this level of diabetic eye screening and everybody else is here, the next step is not to berate them, but to sit down and why are you falling behind? What in your office flow? What part of standard work are you not getting? Standard work was brought up before by David, I believe, and that's very important to help migrate away slowly from larger financial incentives, perhaps a few small ones. Doctors, I think, and nurses still have morals and ethics. And if you can play to that, play to tradition of what a good doctor, a good nurse is supposed to be, you're going to get better overall results. We've debated too about our offices. Too many times our individual doctors get some sort of incentive for feedback. And we're finding we really want to give it to the medical assistants too. They should know what the office is doing in terms of their best in class scores. We've actually found recently some very good medical assistants, and those medical assistants are going to be the trainers for the other medical assistants. They've gotten standard work down. So it's not always a top-down approach. It's often a bottom-up approach of grabbing everybody you can in the office ambulatory setting and getting them on board with feedback, performance improvement.
Thank you so much.
Yes, thank you. Walter?
Great discussion so far. I wanted to circle back to something both Dr. Wachter and Crecilius talked about, the 3 midnight rule. This is a rule that I think about quite often because of working in nursing homes. You know, just for those who may not, if I have a patient in a nursing home, elderly woman who develops an pneumonia, needs some oxygen, if that patient has a Medicare Advantage plan, they can actually get the IV antibiotics, the oxygen, maybe some IV fluids in their room often, if they're in a duly certified bed, and the nursing home can bill for a post-acute skilled stay if the Medicare Advantage plan provides the authorization number. But if that same patient has traditional Medicare, I have to send that patient to the hospital where, you know, they might get delirious, they might fall, break a hip, and then come back with all sorts of care transition problems, medication errors. And so this is like it's a real problem. And so I appreciate both Bob and Chuck bringing it up. I guess if I were to take Medicare's view, though, the reason why Medicare allows these waivers for Medicare Advantage plans and ACOs taking double-sided risk is because they are ultimately responsible for paying for the post-acute stay. So there's less of a risk of abuse of these waivers than in patients with a traditional Medicare plan. So my question would be, especially for Bob and Chuck, but anyone else who wants to answer, what kind of, as you thought about this, what kind of guardrails would you suggest Medicare put in place to help prevent abuse of this rule by fee-for-service providers who may not, who may want to take advantage of it?
Yeah, I don't know. I mean, it strikes me that the era when all these rules were put in place was an era where healthcare was an analog system where the data were stored on pieces of paper. And you look at the connection, the fact that all of the data that the hospital has are digital, and we have now advanced analytic tools, you would think that we would be able to figure this out. It just doesn't strike me as the hardest problem in the world to decide whether patients should appropriately be in a hospital or should appropriately could be cared for in place in their nursing facility. And you know, it feels like, I think it's whoever said before, that there's no way to have an abuse-free system. You have to sort of look at what is the net impact of the current rules. And as you know, Walter was just describing that scenario, that sounds like a happier scenario for the patient to stay in place, get the care that they need where they are without transitioning. It sounds like it's going to be massively less expensive. And if the cost there was that every now and then you have an unethical provider and you can't catch them through existing systems, still think net you're probably ahead, not sticking with the rules that really sort of incentivize not fraudulent, but massively dysfunctional, counterproductive behavior. And so I'd be kind of looking, I think the question of can you catch the unusual instances of fraud, I think in an environment now where the systems are digital is another advantage of if we can figure out a way of digitizing the post-acute setting as well, so that we can look at this across the continuum and have the same digital record that we can analyze for the patients in the right setting, getting the right care, and the lowest cost setting. It feels like that would be an easier thing to do if the entire system was digitized. But it just strikes me that the incentives that are embedded in the current system get people to do the wrong thing, and often know that they have to do the wrong thing. It's the only way that they're going to be compensated. That creates moral hazard. It creates, I think, ethical issues for everyone. And we're not talking about perfect. We're talking about a very bad status quo that we should get better.
I can certainly add that, Bob. It's it's not that hard to put the guardrails in place. You have to have criteria to be admitted to the hospital. You use similar criteria for a nursing home paid skilled admission. You know, fever above, blood pressure below, vital signs and symptoms that you have to meet. Physician has to come in and certify that. The home can't do it. They're not a medical professional to determine that. And typically these models would involve an extra payment to both the physician to make sure they get there in time and the nursing home. A little extra per diem for their work, time, and effort. It is a money saver by far.
And it's much better for the patient. And I think
yes,
when we talk about moral hazard, I think we also have to weigh, there's a moral hazard to having a two-tiered system where one person stays in their bed and gets the care that they need, and another one gets picked up and gets disoriented, gets put in an ambulance and moves forward on that. You know, I'm going to be really careful about saying this because I said it one time, and if you can picture the scene from the old Frankenstein movie where people are storming the castle, but, you know, we have healthcare, what I would say is very data rich, information poor, and insight starved. We have so much data on everything. We get very little information out of it, and we don't use the data that we have to gather the insights, some of which people have shared here today. How do we start taking this incredible amount of data and getting better insights from it, and then designing the care around that, rather than saying, how do we buff up what we think we can all agree is a somewhat dysfunctional healthcare system around the edges and hope we get a better result from it?
One of the regulatory barriers I'd like to bring up in this sort of analysis, telemedicine in nurse homes is limited to every 2 weeks, period. It doesn't matter how sick the patient is. We're the only site of service. And if I have somebody sick that I've seen, I can't help if I did a telemedicine visit, I'm across town, they're calling me about somebody really sick that I should see. I can't do it, or I do it for free in order to keep the patient in place where they should be. So that every 2-week rule needs to go away if we're going to do this successfully.
Thank you. Larry?
Very thought-provoking discussion. We've spent a lot of time talking about post-acute transition. I'm going to raise a pre-acute transition. And this is what's arising in primary care and multiple specialties. I work in the GI space, and I don't want to mention specific companies, but there are many B2C digital health companies that are developing totally telehealth-based products focused on patients who have low morbidity conditions. In the GI space, it would be irritable bowel syndrome, but maybe also mild inflammatory bowel disease. And then when these patients intensify and need to be seen by a physician, they need to transition to a healthcare provider that can actually examine them and perform procedures, possibly hospitalize them. And so this is a new transition that I don't think we've really discussed as yet, but it's one that's only going to grow as the digital health revolution continues down its path. And I'm just interested in what the panel's opinion is of this and how these disintermediated healthcare entities provide total longitudinal care for patients. How do we deal with this?
I think you've asked the trillion-dollar question. And in many ways, you could see that this would be the source of great innovation because these companies can come in and take on a single or a relatively constrained group of conditions and innovate in a way that legacy organizations are just too complex and interconnected and hidebound to do. And in some ways, you have the Southwest Airlines story. You have, taking a piece of the market, innovating in that piece, and then ultimately growing out to build a more comprehensive set of services, because I'm guessing your inflammatory or your irritable bowel company would like to do all of GI. And if you're a gastroenterologist, they'd love to either hire you or replace you. On the other hand, you can develop something that is, just totally fragmented from the patient standpoint and markedly inefficient. You've built in tons of additional transitions. It's a core issue in medicine, even pre-digital. When do we call something a specialty? When is it valuable for the patient to see a diabetes person rather than their primary care doctor? And I can easily imagine that a hypertension solution would work well and probably be more efficient and cheaper than having to go for your primary care doctor everywhere. So the cure for this is probably payment models that push for integration, and whether integration is a single system or integration is a cobbled together system of individual entities that are brought together through digital glue, I think is going to be determined by the market, basically. I think you're going to see a lot of this. You see a lot of startup activity in this space. I worry about it from sitting in a big academic medical center, where are we going to be only left with, the most complex of a complex, and is that going to pay our bills or not? And also as a training environment, if I'm trying to train a family medicine doctor or an internal medicine doctor, and all of the basic stuff is done in some other space, and by the time they get to us, they only get there when they need a transplant, I can't train them anymore for general medical practice. So I think it raises a ton of questions. I think it's inevitable that this is going to happen, and I think it's got to be monitored very carefully by HHS and others. I don't think there's going to be a way of putting a lid on it and saying we can't do this or see this. I think the question is then, what is the model? What is the payment model that makes sure the patients don't fall in the cracks as they're getting care from multiple providers? But they do today. I mean, they see you for GI, and they see me for general medicine, and they see somebody else for OB, and we've got to figure out how to integrate. It's just going to create new pressures to do it, but also in an environment where the digital tools for integration are going to be better than we've ever had in the past.
Yeah, I spend a lot of time with employers talking about what they're looking for their self-insured plans as part of our value-based care work. One arm we've been talking about is Medicare. I think in the Medicare Advantage space is probably where you're seeing the most of the B2C type innovations and a willingness. They're willing to take risk for performance. Medicare Advantage is capitating a group of providers, and they're looking for help in performing in those risk-based arrangements. That's where I worry about disintegrating care too much, and that's why I've been talking so much about including all the members of the healthcare team, because my biased opinion is I don't want hospitals to be left to only the most complicated and no funding to take care of the most complicated. I think panels like this one need to be more forward-thinking, and I appreciate the fact that you all get together to talk about these things, because if we don't get ahead of it, we will be left to that. And when I have, if I have stage 4 cancer, I'd like to have that treated in the most effective way. I don't want it to be the least invested in area of healthcare. So, but your point is, this is a sign that we really need to be going further faster. When we sit with employers, they're frustrated. They're frustrated because we're not good at talking to each other. They are leading. They're funding the majority of healthcare in the country. And so they are leading where healthcare is going to go. Self-insured employers, commercial insurance subsidizes all government programs and the way that healthcare is delivered. So, and they want, Toyota builds cars, Southwest Airlines flies airplanes. They want pilots to be sitting in the cockpit flying the airplane, not at home with their, GI condition. So that's what leads them to look for GI solutions that can help them run their business. So I would say we're doing exactly what we should be doing. We just need to go further faster in groups like this to figure out how we do a better job of providing integrated healthcare and embracing these digital solutions. Because you're right, then when you transition that IBS to you in person or to an emergency room, we don't know what's been prescribed. We don't know what actions have been taken. That's not the right thing for the patient. I just think we have to offer a better solution and embrace the technology where we can, but in an integrated way. And maybe that's part of the incentives of digitizing post-acute. It's also how do we bring in this interoperability if you're going to put out a digital solution, who does it have to talk to? That's where regulation, I think, could help us. How does it have to communicate so that we understand what treatment's been offered and we can offer the next step in an effective and safe way for patients?
Well, and I think there's asymmetries in gathering funding as well. So we've seen some organizations that have, said, here's what we're going to do, here's how we're going to take care of patients, and here's what we've shown. And they've been able to gather literally billions of dollars of funding to continue that organization. And we look at our results, and where our results are better, yet we can't take our healthcare system public. So I think that there are funding asymmetries, but I say shame on us if we're not moving in that direction as well. We just have bigger barriers in getting the funding than perhaps a smaller startup does.
Thank you for this conversation. Unfortunately, we've run out of time, but I want to thank everybody, this group and including all the other groups that we've met with this morning. This has been a great day and given us a lot to think about, and we really appreciate your perspectives on all this. And at this time, we're going to take a short break, and we're going to come back in about 10 minutes, and the group is going to talk about the things we've heard today and kind of summarize what we think we've heard from all the panels. So really, again, appreciate your time and input. Thank you.
Thank you for the opportunity.
You're welcome.
Welcome back. As you may know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on improving care delivery and integrating specialty care in population-based models. We now have time for the committee to reflect on what we have learned from our sessions today. We will hear from more experts tomorrow, but want to take the time to gather our thoughts before adjourning for the day. Committee members, I'm going to ask you to find the potential topics for deliberation document in the left front pocket of your binder. It's at the very back. To indicate that you have a comment, please flip your name tag up or raise your hand in WebEx. This is really important to capture the themes of what we've learned today from all these very rich discussions. So I'll give you a moment, and who would like to start? Lee.
Thank you. I was taking notes as people were talking, and a couple of comments, and then I think a series of quotes that sum up my takeaway points. So one is that we heard a lot about challenges of transitions for medically complex patients and involving specialists in care and the complexity of transitions. Made me wonder about the TCM codes. Right now it's a construct that there's two levels of service only dealing with essentially the timing of the service and the medical decision making, that perhaps we need to think about a new construct that takes the complexity or the number of team members involved instead of just the medical decision making per se, and that we start changing our thinking that the unit of measurement is not the provider but essentially the team, which was mentioned multiple times. So I think there may be a opportunity for Medicare to add a third highest complexity level code and then have a 3-level gradation of number of team members involved, like 1 to 2, 3 to 4, greater than 5 or 6, etc. So second comment was that I was struck by the number of speakers who again reflected themes from prior meetings about the absolute centrality and need of full interoperability of data, again pointing to that idea of a health data utility and the need for significant investment and then regulation requiring that movement. And the framework is in the country, but it's very disintermediated and a lot of barriers on a state-by-state, region-by-region basis. So that came out to me strongly. And then perhaps I'll save my quotes that summarize some other points to the end of our comment period.
Thank you, Lee. Great comments. Angelo.
Yeah, so at a high level, I kept hearing certain themes over and over, and one of the themes was teams. And our payment model seems to be very focused on physician reimbursement for an activity that nobody else can bill for, and or that it's not paid based on a team structure. And so I think that's something that we need to consider as a PTAC is, can can and should others be able to bill for some of these services that aren't physicians, and or should we be paying based on a team construct as opposed to an individual physician construct? The other things that I heard, again, going back to data and data as a utility, creating standards for ambulatory situations as opposed to just inpatient data integration. I like the meaningful use example that Wachter used, and should we be doing or incentivizing that in nursing homes and other places? And then a lot around communication and just how difficult it is to communicate across these silos of care. Right now, most of it having to be manual or emails or some. Is there a better way? Can we incentivize communication both in the care model so that people are aware? And maybe that will trigger some investment into various communication technologies. And so those are some of the common themes that I kept hearing throughout the day today.
Thank you, Angela. Very helpful. Larry.
I have 3 comments. The first of which is this word transition needs to be applied to our process as well. So, I know we've set this goal out for 2030, but how do we get there? And so I think there's some blocking and tackling that has to be done in the fee-for-service environment to help us get to the value-based care environment. And the issue of the TCM codes, I mean that's something that's already in existence. They don't have to create a new code. It could help improve patient outcomes and help build a value-based model when we can actually see how many TCM codes are being used by specialists, how much money has to be appropriated to this process. So I think we need to walk through the transition phase to value-based care in this transition of care model. The second thing is I think we need to stop using the word discharge. Okay, I mean, no more discharge summaries. There's a transition summary. The discharge summary implies that we're done with what we had to do and we're discharged. Patients discharged from our care. No, not my problem, right? And any of us who've lived this in practice knows that you're busy making rounds and you get a call from a nurse. Mrs. Jones just got discharged. Well, did the hospitalist discharge? Yes, doctor. Okay, fine with me. And you're done. Your punch-its pilot. You've washed your hands. And so I think the word transition probably needs to be everywhere. These are, transition summaries. I understand. I like the point that you should start thinking about the transition from the time that patient gets admitted. And the third thing that I think I brought up at the end, which I think is a real issue here, and I love the way it was answered. We have pre-acute as well as post-acute transitions, and digital technologies are creating new provider entities. We have to figure out how to integrate them into the standard care so that we don't disintermediate providers and disintermediate hospital systems, which we need when the patients are really ill, and yet we don't want to thwart technology. We want that to grow, but the worst thing the one thing we want to avoid the most is fragmented care for the patient. You don't want a patient, standing there with nobody to go to because they've been getting their care from a B2C digital provider and no transition was established. So those are the 3 things that I come away with from a wonderful meeting today. The PCDT team did a fantastic job. Great presentation today, Walter. Great selection of SMEs. The gears in my head were going all day.
Thank you, Larry. Jen.
I couldn't agree more that there was a fabulous discussion today. I too am going to make 3 comments. We heard that when TCM codes are billed, it improves patient care outcomes and decrease costs. But what I was struck by was what is the role of payment policy in incenting acute inpatient care facilities to be more engaged in having a successful transition to TCM work. So really this idea of a push versus a pull. And there was some discussion early on around discharge planning, maybe not using that word anymore per Dr. Kaczynski, but around MDRs and in the inpatient space, there's this work being done. But currently, when we hear the statistic of 20% of Medicare payments going to unplanned readmissions, it's very clear that the readmission penalty is not working. It's not a big enough stick. So what are some other incentives or penalties that can be put in place to really engage acute inpatient care facilities to do a better job of transitioning care? And then to call out, I think there's two different levels of work that we heard about today. Discharging to home for certain patients could be harder than discharging to a facility, and maybe thinking a little bit through what that work looks like. That's comment one. Comment two around the transition of care management codes. I think I was also struck by thinking about our last meeting around integration of specialists in total cost of care models. And TCM codes currently don't incent co-ownership of patients. And at our last meeting, we talked about the scaling and fluidity of certain care conditions that require specialists to have a higher level of engagement at certain times in a care episode and then scale back and transition to primary care. And in some cases, in the acute care setting, it would be appropriate to do a handoff to a specialist, but then transition it back to primary care. And these TCM codes don't allow for that, in addition to the interprofessional and what I'm calling out as the interdisciplinary part that we know is important, and a payment model could incent that. And then I'll call out the statistic that you all know, but to echo it again, that 76% of primary care physicians don't even know their patient was admitted. So obviously that needs to be taken into consideration. My last comment is around palliative care and the fact that we know that there's high value patient outcomes related to involvement and integration of that care team, interprofessional and interdisciplinary. And I thought the comments around making palliative care services for the seriously ill explicit versus implicit was something that was a really good recommendation. But unfortunately, that service is around cost mitigation, not revenue generation. And our current payment models, and certainly the fee schedule, don't acknowledge that really important work. And I think there's really an opportunity for us to think about how to endorse that. And the levers I heard today could be payment related. Another lever that was recommended was regulatory. And the example in the VAD space, which at an academic medical center, we have a VAD program. I'm not sure regulatory is the right lever, but I liked the idea of thinking about different levers to incent good care model design. I was surprised there wasn't a recommendation around a medical home-like model that integrates palliative care, because that seems that might be valuable.
Thank you so much, Jen. Jim.
Thank you. I, like everybody else, I had an experience where I couldn't write fast enough and was getting cramps and stuff in my hand. The things that I would add, one of the things that Larry brought up that I thought was really very important was the notion that it's pre and post acute transition, right? That's really the work, and the policy that supports that is this idea of, in one sense, you're reducing waste, and in another sense, you're preventing waste, right? If you're covering the waterfront from a policy standpoint, and the policy is reducing waste, right? And it's before and after. And the second thing that I observed was this, I had this thing where it said the market reality is something that is very, very powerful. I'm talking about the delivery system market now, where, and specifically when we get into talking about physicians, the physician side of the delivery system that's going to make transitions effective. And we know that it's not only physicians, but we know that physicians have a role in it. And we know that it's a 75-25 split right now, or 70-30 split, where you have employed, which is more of a command and control centralized functioning, but the innovation within that employment structure is going to come from a lot of different places. And then on the 25, a lot of academic places and a lot more informed, and can really accelerate innovation if the marketplace, the way it's designed and the way it's incentive allows for it. Similarly, in the 25%, there's going to be this magic that's being found out there in that group of people that we have to harness as well. So we have to have our eye on both of those groups. If we truly believe that both groups could add to the future innovations that we can't see for today, like how we use, as you were saying, the B2C stuff, how everybody finds a unique use case, if you will, or how they found magic in using new digital technologies. So the design of the future reimbursement system for me was saying, well, man, that's got to be a little bit flexible to be able to cover both of those. And so there's incentives needed, and doctors, as we know, if we just focus on what the doctors are saying, like when I was managing a big physician group, I said, look, sometimes time relief for me is more important than the economic reward. In fact, sometimes you can't pay me enough to take on another activity. So, but if you can take some burden out of the system for me, I can lean into doing this. So that might solve some of our workforce difficulties that were raised, particularly within the primary care space, and from the physician side, by having time-based, like time relief incentives built in to reimburse, and of course maintaining consumer choice is a powerful driver for innovation, because consumers will then walk, if you will. They'll use their feet to decide, I'm going to go here at Baylor versus some other place, because Baylor's doing a better job, that the experience is better. So that kind of tells me that our performance metrics have to be very consumer centric. And I think that was a big takeaway for me today. Thank you.
Thanks, Jim. Next, we're going to go to Josh, and I just want to give a frame. We've got about 10 more minutes. We're going to go Josh, Lindsay, and then finish with Lee.
Great. Well, I agree. Really full day. Lots of comments that I agree with have been said. I think the thing that is kind of rattling around in my mind is this idea of yes, but. And so I really resonate with the idea of infrastructure. I like Bob's example of high tech. Yes, it's good, net, but also it created problems, including ones that he mentioned, including primary care burnout and the increases in work. The idea that I think David Herman mentioned about having lots of data but not much insight, right? I think sped by high tech. So yes, and so I think that the takeaway for me is in the future we probably need more infrastructure, but it also will create new problems for us. We should just steel ourselves to that. The other is kind of with respect to transitions, and I think there's been a lot of really thoughtful reframing around what we talk about there, but very practically around kind of codes like TCM versus more global incentives. I feel like, again, it's a yes, but to me. And what I mean is global incentives, of course, are important. We spent multiple meetings talking about that, how it creates a holistic view. It avoids myopia, which is really good. But also for those really incorrigible things like a very vulnerable, complex transition period, maybe a readmission, penalty is not enough, and maybe ACOs aren't enough. We heard from Diane Meyer, ACOs have been around for a long time. They've been, what did she say, slow to pick up on palliative care. That make the case that many of those population-based models have been slow to pick up lots of things, actually, surgical care, this and that. And so I think for those really critical parts, having multiple things is probably not a bad thing, you know, so having TCM on top of global incentives is probably okay. So yes, more population-based models, but also I think specific codes really can't hurt.
Thank you, Josh. And Lindsay.
Thanks, Lauren. I think a lot of smart things have been summarized already, but I think some foundational things that continue to resonate from last meeting to now are just some foundational things about the accessibility of data, and how important, especially at transitions, the pre-existing relationship with a PCP and the identification with the PCP is critical to ensuring that someone's ready to pick up that ball quickly in the time needed to act on anything. So, I mean, it strengthens everything just around the importance of primary care workforce and payment to make sure those people are there when we're ready to do the transition or the discharge. Absent a PCP, having an entity that's willing to take on that responsibility of finding someone quickly could substitute, but the likelihood that a hospital is going to be able to give a list of PCPs in the community and get someone in for an effective transition is next to zero. So I think really hearing this last conversation about standard work and making it easy to do the right thing struck me. You know, there's things we know that are important. Getting data to PCPs, having patients identify with PCPs, and instead of coming up with new fancier things, how can we work on using the data and the things we know and actually executing on them? How can that make a difference in some of the outcomes and what we're talking about? And I think, you know, some of the things may be more actionable in terms of making it easy to do the right thing. Could be things like, how do we increase incentives to patients? How can we decrease co-insurance, decrease the barriers to using these services that we've now seen studies that show there's efficacy in reducing costs and improving outcomes? And how can we get enough payment to primary care so they can, or palliative care, whoever we designate as or a specialist who's willing to take on that continuity, longitudinal relationship, but using a multidisciplinary team with the skill set that's going to impact outcomes. So, not that this is simple to solve, but I just am less convinced that it requires truly new things and then doubling down on execution of things that we have more and more data on that work. So I think final comment would be along those lines, having a PCP relationship, especially in the Medicare population, could be an area to lean on even more. And how could we encourage the identification of PCP outside of the MA space or other payers that have an interest? So, good discussion, though. Thank you all.
Thank you, Lindsay. Walter J. Cheney wanted to give you a chance.
I really don't have anything to say that is not redundant to what everyone else said. So,
I think we cover everything pretty well.
Okay, Walter.
Sure, I'll just make a few quick comments here. More reflecting on my fellow committee members' comments, which is more thinking, in addition to the panelists that we had today. So I think first, we've heard the importance of the interdisciplinary team. Again and again, that was a theme for me. That was also evident from the environmental scan as well. I'm not sure we really heard from our experts how to pay for it. I think that was your question initially, Lauren, but maybe Lee has a good idea here that we can explore with our experts tomorrow. Secondly, I think one of the things that the ASPE-NORC study showed is that there is more pickup of TCM code usage in ACOs, and we also heard from our SMEs today that they felt that was also the case. In fact, I think one of our experts said that doing good transitions is really hard to do in a fee-for-service environment. And I wonder if there's a way that maybe CMS or CMMI can help figure this out a bit by tying outcomes to the billing of that code. Right now, I feel like the usage of the TCM code is really like a category 1 activity. So you think about the HCP LAN categorization of value-based care. the current usage of TCM code is just category 1, a straight fee for service. It doesn't really matter if I do a good job or a bad job. There's no outcomes tied to it. Is there a way that we can somehow tie outcomes to the billing of that code to make sure that actually there's some value-based payments tied to usage of that code and hopefully improve the outcomes associated with that code? And the last thing I would just highlight is something that I think Karen said at the very first session today about the need for payers to communicate more with providers in terms of performance data. You know, it kind of made me think, I'm sure larger practices have more access to payer data, but smaller practices like mine, it's hard to get performance data from payers, and I wonder why. You know, like why shouldn't the Medicare Advantage plans, my practice contracts with, send me my performance data and that of all my other providers in our group on readmission rates, transition code billing, ED visits. I think that is something I'd like to ask our payer experts tomorrow.
Thank you, Walter. I'm going to call out 2 themes and then turn it to Lee to close us out with some quotes. So definitely the strong theme of longitudinal cross-sector integration for really integrated delivery, that the focus on health equity and health-related social needs is really driving integration of social service, community-based organizations across sectors. And that's also driving some interest in hubs or coordinated approaches to actually meet these gaps in service, not only in workforce, but in preventing the syndrome of referring to nowhere, screening, and then not having anywhere to refer. So a lot of really rich content today. We want to thank everyone for their active dialogue, active engagement, and I'm going to turn it over to Lee to close us out.
Thank you, Ms. Chair. Just have some quotes from some of the speakers that really resonated a lot of the points we've heard today. Simple brain, I look for simple points that I can remember. Starts with Dr. Diane Meyer, who said, Mother Teresa is not a scalable model. Speaking of the need to have a deliberate build, the system drives the outcomes you desire. You can't just count on people doing it out of the goodness of their heart. Secondly, when the requirement is applied, the resources will be supplied. Speaking to a pathway for thoughtful and careful regulatory adjustment. Dr. Chuck Crecelius said the best transition is no transition. I think speaking to both the workforce, primary care workforce, and good data. Next, moving to Dr. David Herman. He was speaking to the need to just simply commit to a delivery model, even though it's not all clear how it's going to work. And he commented that here in Wisconsin, we just get in the canoe. We don't spend much time balancing. Secondly, referring to the, fanciful belief that some glorious time in the future there'll be adequate primary care or frankly physician or nurse workforce supply, which isn't going to happen, is just those people don't exist. And then lastly, he finds that we are all data rich, info poor, and insight starved, which I resonated with. Ms. Jenny Reed from Baylor Scott & White mentioned, I like models that incentivize working together. Absolutely. And telling, and that so many things built on a fee-for-service mechanism, CPT driven, are individual provider focused. And then finally, she reiterated multiple times, simple calculations, which is important to me as well. And then ending with Dr. Bob Wachter, who spoke to, I've seen a lot of primary care crises over the years, and it's never been more urgent. Thought that meant a lot. And then finally, if you don't start at payment parity for hospital at home, you won't get the activation energy to shift. A little chemistry model there. So.
Thank you so much for that excellent summary, Lee. We want to thank everyone today for your active participation. Really deep thanks to our expert presenters who took time to do really rigorous presentations and inform this discussion today. I want to thank our ASPE, NORC, and PTAC colleagues, and also those listening in. We'll be back tomorrow morning at 9 a.m., and we'll feature 2 listening sessions, as well as time for public comment. We hope you will join us then. Thank you. This meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.